Good day. Today we are discussing disorders that present with diarrhea. Acute diarrhea is the sudden onset of an increase in the normal water content of stool. In general, humans lose approximately 10 milliliters per kilogram per day of fluids in stool. The increased water content of diarrhea results in an increased frequency of stools from 3 or more times daily to more than 20 bowel movements in a 24-hour period. Diarrhea is an increased frequency of defecation, usually greater than 3 bowel movements per day for a daily stool weight exceeding 200 grams. Practically speaking, diarrhea is present when the patient is making more stools of lesser consistency more frequently. There are 4 basic mechanisms of diarrhea: increased intestinal secretions, decreased intestinal absorption, increased osmotic load, and abnormal intestinal motility. So just to summarize, diarrhea can be divided into secretory diarrhea, malabsorptive diarrhea, osmotic diarrhea, and dysmotility diarrhea. Normally, the jejunum receives between 6 and 8 liters per day of fluid in the form of oral intake and gastric, pancreatic, and biliary secretions. Dietary intake actually constitutes a small portion of the jejunal load, which is 1.5 liters. A healthy small intestine absorbs nearly 75% of the fluid to which it is exposed. The 2 liters of fluid not absorbed by the small intestine then enters the colon, where fluid is absorbed at an even higher rate. The absorptive power of the colon approaches 90% efficacy and far exceeds that of the small intestine. In fact, the colon can make up for a decrease in small intestinal absorption. Under normal conditions, very little fluid, less than 100 ml, is lost in the stool each day. In diarrheal states, normal intestinal physiology is disrupted. At a cellular level, intestinal absorption occurs through the villi and secretion occurs through the crypts. Fluids are absorbed by 2 mechanisms: passively with the transport of sodium and actively with the absorption of glucose. Selected enterotoxins block the passive sodium resorption and specifically stimulate sodium excretion, resulting in a net loss of fluid. The glucose-dependent mechanism of water absorption, however, is unaffected by these toxins and can be exploited by including glucose in rehydration treatments. The composition of oral rehydration therapy recommended by the WHO is based largely on this physiology. In addition, diarrheal states, enterotoxins, inflammation, or ischemia disrupt the structure of the intestinal villi preferentially with less involvement in the crypts. As a result, diarrhea occurs because of diminished intestinal villi absorption and unopposed crypt secretion. The crypts are more resilient than the villi after injury. Another mechanism by which disease processes cause diarrhea is by the delivery of an osmotic load to the intestine. For example, administration of a laxative results in the collection of an osmotically active non-digestible agent within the intestinal lumen. Other substances such as diet products and medications like colchicine have similar effects. Osmosis occurs, drawing fluid into the intestinal lumen and results in diarrhea. Increased intestinal motility also causes diarrhea. This mechanism is responsible for diarrhea in patients with irritable bowel syndrome, neuropathies, or a shortened intestine secondary to surgery. Diarrheal illness is primarily a viral infection due to norovirus, but can also be caused by bacteria and parasites. And in the current situation, it can also be caused by coronavirus infection. Antibiotic and nosocomial diarrhea is most often caused by C. difficile. Many drugs affect gastrointestinal function. Erythromycin accelerates gastric emptying. Clavulanulates stimulate small bowel motility. Other drugs that cause diarrhea are laxatives, sorbitol, lactose, NSAIDs, and cholinergics. Inflammatory bowel disease, ulcerative colitis, and Crohn's disease are characterized by diarrhea. If patients have fecal evidence of inflammation and Shigella, Salmonella, Campylobacter, C. difficile, or Entomoeba histolytica, and if these have been excluded, in particular, suspect inflammatory bowel disease. Less common causes of severe diarrhea include gastrointestinal bleeding, thyrotoxicosis, toxin exposure, and mesenteric ischemia. Clinical features of diarrhea when it comes to the history requires us to confirm a diarrheal illness and focus on identifying its cause. We determine whether the diarrhea is acute, which is less than 3 weeks, or chronic, which is more than 3 weeks. The acute diarrheas are of greatest concern to the emergency physician as they are more apt to be a manifestation of an immediately life-threatening illness such as infection, ischemia, intoxication, or inflammation. We also ask directed questions to characterize the diarrhea. Is it bloody or melanic? Is it associated with possible food poisoning or the ingestion of certain foods such as milk or sorbitol? Does it resolve or persist with fasting? If so, this can indicate an osmotic or secretory diarrhea, respectively. Are the stools of smaller volume, localizing to the large intestine, or of larger volume, indicating small intestine pathology? What symptoms accompany the diarrhea? Is there fever or abdominal pain, which may suggest diverticulitis, infectious gastroenteritis, or inflammatory bowel disease? Seizures accompanying diarrhea often point towards shigellosis, but could also indicate theophylline toxicity or hyponatremia. Does the patient have heat intolerance and anxiety, suggesting thyrotoxicosis, or paresthesias and reverse temperature sensation, suggesting ciguatera poisoning? We also obtain medical and surgical history. The differential diagnosis for diarrhea is broadened if the patient is immunocompromised. Is the patient taking medication that may cause diarrhea? Has the patient recently traveled outside their residence or to a rural area? Rural hiking places place the patient at risk for giardia, particularly if water purification procedures are not strictly followed, whereas travel to other third world countries increases the chances of parasitic infection and traveler's diarrhea. A patient's occupation may also be a clue to a diagnosis of organophosphate poisoning. Some examination findings helpful for diagnosis include thyroid enlargement, masses, oral ulcers, erythema nodosum, episcleritis, or an anal fissure, which would point toward inflammatory bowel disease. Rayner's syndrome, the triad of arthritis, conjunctivitis, and urethritis or cervicitis, should cause concern for Salmonella, Shigella, Campylobacter, or Yersinia infection. Abdominal and rectal examinations are critical. Especially in the elderly, fecal impaction may result in diarrhea as liquid stool passes around the impaction. We pay attention to the presence or absence of surgical scars, tenderness, masses, or peritoneal signs. We check the stool for blood because bloody diarrhea can be caused by inflammation, infection, or ischemia. An elderly patient with bloody diarrhea and abdominal pain out of proportion to the physical examination may have mesenteric ischemia, which is a true emergency. Since most diarrheal illnesses are self-limited, viral, or last less than 24 hours, most patients who present within 24 hours of onset do not need any microbiologic examination. Patients who have severe abdominal pain, fever, and diarrhea that is voluminous, purulent, or bloody may have acute infectious diarrhea associated with the following: Salmonella, Campylobacter, Shigella, Shiga toxin-producing Escherichia coli, Yersinia, Vibrios, or C. difficile. When applied to a stool sample, right stain allows detection of fecal leukocytes. Historically, it has been used to differentiate invasive from non-invasive infectious diarrheas. In the past, this was an important distinction. Physicians were reluctant to prescribe antibiotics for patients with infectious diarrhea because of the fear of prolonging the Salmonella carrier state. They therefore reserved antimicrobial treatment for toxic patients who felt they had truly invasive diarrhea. Many physicians now treat patients with diarrheal illness with antibiotics regardless of whether or not the diarrhea is invasive or bacterial in origin. Bacterial stool culture is expensive and labor-intensive, and it plays a very minor role in the emergency evaluation of diarrhea. There is a less than 5% diagnostic yield of stool cultures unless there is careful patient selection. So we obtain stool cultures for bacteria in ill children, toxic patients, dehydrated patients or febrile patients, patients with a diarrheal illness of more than 3 days, patients with blood or pus in the stool, and the immunocompromised. For systemic illness, fever, or bloody stools, we test for Salmonella, Shigella, Campylobacter, Shiga toxin-producing E. coli, or amoebic infection. We also suspect parasitic infection and evaluate stool for ova and parasites in travelers exposed to untreated water and those presenting with diarrhea for more than 7 days. Stool tests for ova and parasites lack sensitivity because many parasites are fastidious and shedding of the organisms is intermittent. Multiple samples may need to be collected for a positive result. Direct immunofluorescence staining improves the sensitivity for detecting Giardia and Cryptosporidium. C. difficile infection is the commonest cause of antibiotic-associated or nosocomial diarrhea. Diagnosis by the C. difficile toxin assay. Unfortunately, this assay has a 10% false negative rate, and the turnaround time on the test approaches 24 hours. If the diarrhea is not infectious in origin, data acquisition should be dictated by the differential diagnosis. Severely dehydrated patients need serum electrolyte and renal function measurements. Serum drug levels can assist the physician in making the diagnosis of theophylline, lithium, or heavy metal intoxication. In patients with a history of abdominal surgery, abdominal films may help rule out partial obstruction as a cause of diarrhea. A chest radiograph may help diagnose Legionella pneumonia in a patient with diarrhea and a cough. For patients in whom mesenteric ischemia is suspected, obtain a serum lactate, IV contrast CT scan, or mesenteric angiography. For severely dehydrated patients, IV hydration is needed. Oral rehydration with a glucose-based electrolyte solution can be initiated in patients without associated nausea or vomiting and without severe dehydration. Glucose-containing caffeine-free beverages are the fluids of choice. The glucose transport mechanism is unaffected by enterotoxins, allowing for water absorption in the small intestine. For patients who can't afford to buy it, Gatorade is a good rehydration choice for patients with mild dehydration. The World Health Organization recommends a solution with a higher sodium concentration for more extensive dehydration. Mildly dehydrated patients should aim to drink 30 to 50 ml per kilogram over the first 4 hours. For moderate dehydration, patients should drink 100 ml per kilogram over the next 4 hours. They also counsel patients to avoid caffeine, which stimulates gastric motility, and sorbitol containing chewing gum or raw fruits, which can worsen osmotic diarrhea. Initially, avoid lactose until the colonic villi are able to recover and produce the necessary digestive enzymes. We encourage patients to attempt early solid food intake, but with the previously mentioned restrictions, because eating expedites the recovery from diarrheal illness. Viruses cause the vast majority of infectious diarrheas, followed by bacterial and parasitic organisms. A history of foreign travel is associated with an 80% probability of bacterial diarrhea. The most important risk factor for travelers' diarrhea is the destination of travel, with the risk increasing with travels to areas of lower socioeconomic status. Countries in Asia, Africa, Latin America, and parts of the Middle East are considered high-risk destinations for travelers' diarrhea, with incidence rates ranging between 20 and 75%. Other risk factors include the level of food contamination, the season of travel, because rainy seasons are associated with a higher risk of travelers' diarrhea, the use of a proton pump inhibitor, previous contraction of traveler's diarrhea, which suggests genetic susceptibility, and the type of travel. The major bacteria responsible are the toxin and non-producing strains of E. coli. These strains of E. coli make up most identifiable cases in Mexico and South America. The invasive bacteria such as Campylobacter jejuni, Shigella, and Salmonella are more commonly seen in travelers to Southern Asia. The presence of severe abdominal pain, fever, or bloody stool requires microbiologic studies to rule out bacterial or amoebic infection. We assess the stool for polymorphonuclear white blood cells or fecal leukocytes by microscopy or by immunoassay for the neutrophil protein lactoferrin. The presence of fecal leukocytes increases the likelihood of a bacterial pathogen. However, bloody stool without white blood cells is a common feature of Shiga toxin producing E. coli or E. coli O157H7 and colitis that is due to Entamoeba histolytica. We obtained stool culture for Salmonella, Shigella, Campylobacter, and E. coli O157H7, assay for Shiga toxin, and obtained microscopy or antigen assay for Entamoeba histolytica. Exposure of a traveler or hiker to untreated water and illness that persists for more than 7 days should prompt evaluations for protozoal pathogens. We test the stool for Entamoeba histolytica antigen, Giardia intestinalis antigen, and Cryptosporidium parvum antigen by enzyme immunoassay. Rarely, helminths such as Ascaris, Enterobius, and Scroneloides have been implicated. Treatment of infectious diarrhea includes antibiotics, antimotility agents, restoration of fluid balance, and avoidance of agents that worsen diarrhea. So when it comes to rehydration, we could give fluids such as chicken broth with fruit juices, Gatorade, non-caffeinated sodas, packages of salts and glucose to be reconstituted with boiled or treated water, Cerealite 90 or Pedialyte. For foods, we could give complex carbohydrates such as bananas, bread, rice, apple juice and tortillas, potatoes, crackers, and lactobacillus containing yogurt. Antimotility agents include bismuth subsalicylate with a dose of 30 ml or 2 tablets every 30 minutes for 8 doses and repeat on day 2. Salicylate toxicity may occur with excessive dosing and it may cause bismuth encephalopathy in HIV-positive patients. Loperamide is given 4 mg initially and then 2 mg after each unformed stool for no more than 2 days with a maximum of 16 mg per day. It's the preferred first-line agent for antimotility with minimal central opiate effects. It can be used with antibiotics. Diphenoxylate and atropine can be given 4 mg 4 times a day for 2 days. It's a second-line agent with more central opiate effects since it's a narcotic related to meperidine, and it may potentiate the action of barbiturates, tranquilizers, and alcohol. Antibiotics given for traveler's diarrhea include ciprofloxacin, 500 mg single dose or 500 mg twice a day for 3 days. For moderately severe illness in adults, we complete the 3-day course if a single dose fails and significant drug-drug interactions may occur. Azithromycin is given 1,000 mg in a single dose. It's safe for children and pregnant women. Trimethoprim sulfamethoxazole is given 160 mg over 800 mg for a single dose or twice a day for 3 days. For moderately severe illness, resistance limits reliable effectiveness. And Rifaximin is given 200 mg per orem 3 times daily for 3 days. It's for moderately severe illness and we do not use it for fever or bloody stools, and it has class C in pregnancy. So, we do not use antimotility agents in the subset of patients with bloody diarrhea or suspected inflammatory diarrhea because of the possibility of prolonged fever, toxic megacolon in C. difficile patients, and hemolytic uremic syndrome in children infected with Shiga toxin-producing E. coli. Antimicrobial recommendations for infectious pathogens in adults include empiric treatment but not for bloody diarrhea and not for Shiga toxin E. coli O157H7, being ciprofloxacin 500 mg per orem twice a day for 5 days, with an alternative of trimethoprim sulfamethoxazole DS 1 tab per orem twice a day for 5 days. For C. difficile, we could use metronidazole 500 mg per orem 3 times a day for 14 days, with an alternative treatment of vancomycin 125 mg per orem 4 times a day for 14 days. For E. coli O157H7 and Listeria monocytogenes, we do not give any antibiotics. Yersinia is usually self-limited, but we could give ciprofloxacin 500 mg per orem twice a day for 3 days, or trimethoprim sulfamethoxazole DS 1 tab PO twice a day for 3 days. For non-typhoid salmonella, we can give ciprofloxacin 750 mg per orem twice a day for 5 days, or azithromycin 500 mg per orem once a day for 7 days. Shigella also has ciprofloxacin 750 as its primary treatment, but it's given only for 3 days, and azithromycin is given for 3 days. Vibrio cholerae is treated with doxycycline 500 mg per orem for 1 dose, or azithromycin 1 gram per orem for 1 dose, or trimethoprim sulfamethoxazole DS 1 tab PO twice a day for 3 days. Entamoeba histolytica is treated with metronidazole 750 mg per orem 3 times a day for 10 days, and paromomycin 10 mg per kilogram 3 times a day per orem for 7 days. You could also give metronidazole and iodoquinol 650 mg per orem 3 times a day for 20 days, or tinidazole 2 grams per orem once a day for 3 days, and paromomycin or iodoquinol. For cyclospora, you can give trimethoprim sulfamethoxazole DS 1 tab per orem twice a day for 10 days. And for giardia, we could give tinidazole 2 grams per orem for 1 dose, or nitazoxanide 500 mg per orem twice a day for 3 days, or metronidazole 750 milligrams per orem 3 times a day for 10 days, or paromomycin 10 milligrams per kilogram per day per orem 3 times a day for 10 days. So we admit the toxic patient and any patient who cannot comply with oral rehydration. We also are conservative in admitting those at extremes of age. Most patients with diarrhea can be discharged home. C. difficile is a spore-forming obligate anaerobic bacillus that causes infection ranging from mild diarrhea to severe pseudomembranous colitis. C. difficile infection is the most common cause of bacterial diarrhea in hospitalized patients. The incidence and severity of disease has increased at an alarming rate of 25% per year since 2000. A more virulent strain of C. difficile called North American Pulsed Field Type 1 or B1NAP1027 affects hospitalized patients but can also occur in community-dwelling healthy adults. This strain causes more severe disease that more often progresses to toxic megacolon. The organism secretes two toxins, A and B, that cause a secretory diarrhea. At the most severe end of the spectrum, 3 different syndromes have been described: neonatal pseudomembranous enterocolitis, postoperative pseudomembranous enterocolitis, and antibiotic-associated pseudomembranous colitis. In pseudomembranous colitis, membrane-like yellowish exudative plaques overlie and replace necrotic intestinal mucosa. Recent antibiotic use, gastrointestinal surgery or manipulation, severe underlying medical illness, chemotherapy, and advancing age are risk factors for pseudomembranous colitis. Transmission of the organism is by direct human contact as well as contact with inanimate objects such as commodes, telephones, and rectal thermometers. Hospitalized patients are colonized with C. difficile in 10 to 25% of cases, so the development of diarrhea in recently discharged patients is suggestive of C. difficile infection. There is a linear relationship between the length of hospital stay, colonization with C. difficile, and the development of C. difficile diarrhea. Broad-spectrum antibiotics, most notably clindamycin, second and third generation cephalosporins, ampicillin, amoxicillin, and fluoroquinolones reduce fecal anaerobes which are needed for carbohydrate metabolism and bile acid breakdown. Accumulation of gut carbohydrates can cause osmotic diarrhea, and the accumulation of bile acids, which are colonic secretory agents, also results in diarrhea. Toxin-producing C. difficile then flourishes within the colon. Almost any antibiotic, including metronidazole and vancomycin, can lead to pseudomembranous colitis, and chemotherapeutic agents, proton pump inhibitors, and antiviral agents have also been implicated. Bowel ischemia, inflammatory bowel disease, recent bowel surgery, uremia, malnutrition, shock, advanced age, peripartum status, and Hirschsprung's disease also contribute to the development of C. difficile infection and pseudomembranous colitis. Toxin A is an enterotoxin and toxin B is a cytotoxin that interact in a complex way to produce pseudomembranous colitis and its associated symptoms. The disease typically begins 7 to 10 days after the institution of antibiotic therapy, although symptoms may occur up to 60 days after the antibiotic is discontinued. Pseudomembranous colitis results in a spectrum of clinical manifestations that vary from frequent, mucoid, watery stools to a toxic picture that includes profuse diarrhea of 20 to 30 stools per day, crampy abdominal pain, fever, leukocytosis, and dehydration. Stool examination may demonstrate fecal leukocytes, which are not generally found in more benign forms of antibiotic-induced diarrhea. In 1 to 3% of patients, toxic megacolon or colonic perforation may occur in patients with pseudomembranous colitis. The diagnosis is suggested by a history of diarrhea that develops during administration of antibiotics or within 2 weeks of their discontinuation. Diagnosis is confirmed by the demonstration of C. difficile in the stool and by the detection of the toxin in stool filtrates. The organism is best identified by stool culture using a selective growth medium. This technique has a sensitivity approaching 100% but lacks specificity because the presence of C. difficile does not necessarily implicate it in the cause of the disease. Instead, C. difficile toxins are detected directly using a number of techniques including tissue culture assay, enzyme-linked immunosorbent assays, latex agglutination, dot immunobinding assays, and polymerase chain reaction. Colonoscopy reveals characteristic yellowish plaques within the intestinal lumen. Lesions may be seen throughout the entire alimentary tract, although they are typically limited to the right colon. Colonoscopy is not routinely needed to establish a diagnosis, but may be used in patients who require a rapid diagnosis and those who cannot produce a stool specimen due to ileus. We hospitalize patients with severe diarrhea, clinical toxicity, or symptoms that persist despite appropriate outpatient management. We consult the surgeon for suspected toxic megacolon or intestinal perforation for consideration of colectomy. And we also have treatment for Clostridium difficile infection based on the severity of illness. Mild is defined as WBC less than 15,000 cubic millimeter, with the treatment of metronidazole 500 milligrams per orem 3 times a day for 14 days. Moderate is said to be WBCs greater than 15,000 cubic millimeter, with the patient able to tolerate per orem. So you could give vancomycin 125 milligrams per orem 4 times a day for 14 days. On the first relapse, we give metronidazole 500 milligrams per orem 3 times a day for 14 days. On the second relapse, we give vancomycin 125 milligrams per orem 4 times a day for 14 days, then taper the dose over 4 weeks. And for severe disease with toxic megacolon, we also give metronidazole 500 milligrams IV every 6 hours and vancomycin 500 milligrams per orem every 6 hours, with per orem vancomycin preferred to IV. Crohn's disease is a chronic granulomatous inflammatory disease of the gastrointestinal tract of unknown origin. Crohn's disease can involve any part of the gastrointestinal tract from the mouth to the anus. The ileum is involved in the majority of cases. In 20%, the disease is confined to the colon, making differentiation from ulcerative colitis difficult. The terms regional enteritis, terminal ileitis, granulomatous ileocolitis, and Crohn's disease are all used to describe the same disease process. The peak incidence of Crohn's disease occurs between 15 and 22 years of age, with a secondary peak from 52 to 60 years. It is more common in women. The incidence is increasing, especially in children. It's also 4 times more common among Jews than non-Jews, and is more common in whites than blacks, Asians, or Native Americans. A family history of inflammatory bowel disease is present in 10 to 15% of patients, particularly with early onset of disease. Ulcerative colitis as well as Crohn's disease may be present in other family members, and siblings of patients with Crohn's disease may have a higher incidence of the disease. Smoking, oral contraceptive use, and the use of NSAIDs worsen the course of the disease. The most important pathologic feature of Crohn's disease is the involvement of all the layers of the bowel and extension into the mesenteric lymph nodes. The disease is discontinuous with normal areas of bowel, also known as skip areas, located between one or more involved areas. Longitudinal deep mucosal ulcerations are characteristic. If ulcerations penetrate the bowel wall, fissures, fistulae, and abscesses result. Late in the disease, a cobblestone appearance of the mucosa results from crisscrossing of ulcers with intervening normal mucosa. The clinical course of Crohn's disease varies, and in the individual patient, it's unpredictable. Abdominal pain, anorexia, diarrhea, and weight loss are present in most cases. Chronic abdominal pain, fever, and diarrhea may be present for several years before definitive diagnosis is established. Perianal fissures or fistulas, hematochezia, abscesses, or rectal prolapse can develop, particularly with colonic involvement. Patients may also present with complications of the disease, such as obstruction with vomiting, crampy abdominal pain, and obstipation, or an intra-abdominal abscess with fever, abdominal pain, and a palpable mass. In 10 to 20% of patients, the extraintestinal manifestations of arthritis, uveitis, or liver disease may be presenting symptoms. Crohn's disease should also be considered in the differential diagnosis of patients with fever of unknown etiology. The clinical course and manifestations of the disease appear to be related to its anatomic distribution. In 30%, the disease involves only the small bowel, in 20%, only the colon is involved, and in 50%, both the small bowel and colon are involved. A small percentage of patients present with the disease involving the mouth, esophagus, and stomach. Crohn's disease of the stomach may demonstrate symptoms of peptic ulcer disease. Extraintestinal manifestations are seen in up to 40% of patients with Crohn's disease, and the incidence and types of extraintestinal complications are similar in patients with Crohn's disease and ulcerative colitis. So these manifestations include arthritis, which may be peripheral arthritis, which is a migratory monoarticular or polyarticular pain in peripheral joints such as the hip, knee, ankle, and wrist with effusion, Ankylosing spondylitis, which is pain and stiffness of the spine, hips, neck, and rib cage with limitation in truncal motion, loss of lumbar lordosis, decreased chest expansion, and forward cervical flexion in advanced disease, or sacroiliitis, which presents with low back pain with morning stiffness, relieved by exercise, and also has progressive joint sclerosis. Ocular manifestations include episcleritis, which is eye burning or itching without visual changes or pain, scleral and conjunctival hyperemia, or uveitis, which is acute blurring of vision, photophobia, and pain with perilimbic scleral injection. Dermatologically, the patient may have erythema nodosum, which are painful red raised nodules on extensor surfaces of arms or legs, or pyoderma gangrenosum, which are ulcerative lesions with a necrotic center and violaceous skin, typically found in the tibial region or trunk. For hepatobiliary manifestations, you have cholelithiasis, which varies from asymptomatic stones to right upper quadrant pain, fever, and vomiting. Fatty liver, which presents with mild right upper quadrant pain and hepatomegaly. Pericholangitis, which presents with a mild elevation in serum alkaline phosphatase and is asymptomatic. Chronic active hepatitis, which presents with autoimmune elevation of liver aminotransferase enzymes and may progress to cirrhosis. Primary sclerosing cholangitis, which is pruritus progressing to jaundice, fatigue, and lethargy, with laboratory findings varying from mild elevations of alkaline phosphatase to cirrhosis, portal hypertension, and liver failure, with a male predominance. Cholangiocarcinoma, which presents with an extrahepatic biliary mass, evidence of biliary obstruction, jaundice, right upper quadrant pain, fever, and malaise. Pancreatitis, which varies from painless elevation of serum amylase to clinically apparent central abdominal pain radiating to the back. It could also be associated with drugs such as azathioprine, 6-mercaptopurine, sulfasalazine, mesalamine, olsalazine, and metronidazole. Thromboembolic disease with symptoms of deep venous thrombosis and pulmonary emboli, portal vein, mesenteric vein, and hepatic venous thrombosis is reported. Patients may also have malnutrition, which presents with fatigue, malaise, muscular wasting, and cachexia. Chronic anemia with fatigue, malaise, pallor, dyspnea. It could be microcytic through blood loss or macrocytic through B12 deficiency or autoimmune hemolytic. And nephrolithiasis, which presents with flank pain, nausea, vomiting, hematuria, stones that result from increased dietary oxalate absorption, which produce calcium oxalate stones, and dehydration, which produces urate stones. The definitive diagnosis of Crohn's disease is established months or years after symptom onset. A provisional diagnosis of appendicitis or pelvic inflammatory disease may change to Crohn's disease after imaging or at the time of surgery. A detailed history asking about previous bowel symptoms that preceded the onset of right lower quadrant pain provides clues to the correct diagnosis. Emergency evaluation focuses on determining the severity of the attack, identifying significant complications such as obstruction, intra-abdominal abscess, life-threatening hemorrhage, or toxic megacolon, and eliminating other possible causes of the patient's complaints. Laboratory evaluation should include a CBC, serum electrolytes, BUN, creatinine, and the type and cross-match where appropriate. C-reactive protein levels can monitor disease activity. Fecal markers of inflammation such as calprotectin and lactoferrin are other markers of disease activity. Plain radiographs of the abdomen may demonstrate obstruction, perforation, or toxic megacolon. Abdominal CT scanning with per orem and IV contrast identifies bowel wall thickening, segmental narrowing, destruction of the normal mucosal pattern, mesenteric edema, fistulas, and abscesses, which suggest the diagnosis of Crohn's disease. Extraintestinal complications such as gallstones, renal calculi, sacroiliitis, and osteomyelitis can also be seen on CT scan. Diagnosis is confirmed by colonoscopy. The differential diagnosis of Crohn's disease includes lymphoma, ileocecal amoebiasis, sarcoidosis, deep chronic mycotic infections involving the gastrointestinal tract, gastrointestinal tuberculosis, Kaposi's sarcoma, Campylobacter enteritis, and Yersinia ileocolitis. Fortunately, most of the differential diagnoses are uncommon conditions and can be differentiated by appropriate laboratory tests. Yersinia ileocolitis and Campylobacter enteritis may cause chronic abdominal pain and diarrhea similar to Crohn's disease, but can be diagnosed by appropriate stool cultures. It is not uncommon that a bout of acute bacterial diarrhea may uncover a diagnosis of inflammatory bowel disease. Acute ileitis should not be confused with Crohn's disease. Young patients with acute ileitis usually recover without sequelae and should not undergo surgery. When Crohn's disease is confined to the colon, ischemic bowel disease, particularly in the elderly, and pseudomembranous colitis as well as ulcerative colitis must be included in the differential diagnosis. The aim of therapy, since this disease is incurable, includes relief of symptoms, induction of remission, maintenance of remission, prevention of complications, optimizing timing of surgery, and maintenance of nutrition. Initial treatment consists of adequate fluid resuscitation and restoration of electrolyte balance. We place a nasogastric tube for obstruction, peritonitis, or toxic megacolon. Administer broad-spectrum antibiotics for fulminant colitis or peritonitis. Patients with severe disease should receive IV steroids such as hydrocortisone 300 mg per day or an equivalent dose of methylprednisolone at 48 mg per day or prednisolone at 60 mg per day. Sulfasalazine 3 to 5 grams per day is for mild to moderate Crohn's disease. Sulfapyridine is a byproduct of the colonic breakdown of sulfasalazine. Many of the toxic side effects of sulfasalazine, which include vomiting, anorexia, nausea, headache, diarrhea, epigastric distress, are attributable to sulfapyridine. The active moiety in sulfasalazine is mesalamine. Many of the newer 5'-acetylsalicylic drugs feature a derivative of mesalamine without the sulfapyridine component. Oxalazine and balsalazide are 5-aminosalicylic molecules. The mesalamine formulations are most effective in patients with colonic disease and particularly those with mild disease. So the treatment of fulminant colitis includes restoration of fluid and electrolyte balance, nothing per mouth, nasogastric suction for obstruction, a dynamic ileus, or suspected toxic megacolon, parenteral corticosteroids such as hydrocortisone 300 mg per day or methylprednisolone 48 mg per day or prednisolone 60 mg per day, broad-spectrum antibiotics such as piperazoline, tazobactam 4.5 grams IV 4 times a day or ampicillin 2 grams IV 4 times a day plus metronidazole 500 mg IV 3 times a day plus levofloxacin 750 mg IV once a day. We also observe for obstruction, perforation, toxic megacolon, life-threatening hemorrhage, and intra-abdominal abscesses. Outpatient management for non-toxic patients requires the patients to be on liquids only for the first 48 hours, and oral antibiotics such as ampicillin, trimethoprim, sulfamethoxazole, ciprofloxacin, cephalexin, or rifaximin, and metronidazole or clindamycin are also usually given. An ileal-released form of budesonide at 9 mg per day may be beneficial in patients with ileal and right colon disease. Glucocorticoids are not preferred for maintaining remission because of their complications and concerns about effectiveness. Immunosuppressive drugs such as 6-mercaptopurine, azathioprine, and thioguanine are useful in maintenance as steroid-sparing agents in healing fistulas and in patients in whom there are serious contraindications to surgery. Both agents have been associated with leukopenia, fever, hepatitis, and pancreatitis, necessitating the need for close follow-up, particularly during the initial phase of therapy. The response to immunosuppressives should not be expected before 3 to 6 months following the initiation of therapy. Parenteral Methotrexate at 15 to 25 mg per week is considered third line and has been used following steroid and thiopurine metabolite failure. For perianal disease, antibiotics are the first-line agents and they can help induce remission. Ciprofloxacin at 1.0 to 1.5 mg per kilogram per day induces remission with rates at 55%, which are similar to those in patients treated with mesalamine 4 grams per day. Metronidazole at 10 to 20 mg per kilogram per day is also effective for perianal complications and fistulous disease. Combination therapies with antibiotics and biologic agents have produced dramatic improvements in response. Rifaximin is a broad-spectrum antibiotic that is not absorbed from the gastrointestinal tract. Rifaximin, 800 mg twice daily for 12 weeks, is effective for mild to moderate cases. However, antibiotics raise concerns about precipitating colitis infection. Patients with medically resistant moderate to severe Crohn's disease may benefit from the anti-tumor necrosis factor antibody infliximab or adalimumab. All biologics increase the risk of infections, especially those caused by intracellular pathogens such as tuberculosis. Concern about the emergence of lymphomas and progressive multifocal leukoencephalopathy has limited the long-term use of these agents. Maintenance therapy and the effectiveness of various therapeutic agents in Crohn's disease are variable. Glucocorticoids are not used for maintaining a remission because of the lack of sufficient evidence of their efficacy and the potential for long-term complications. A reduced dose of 5-aminosalicylic acid derivatives is used for maintenance of remission of colonic disease. The addition of sulfasalazine, azathioprine, and 6-mercaptopurine to prednisone does not improve the response rate and increases side effects. Infliximab or adalimumab and an immunosuppressive such as azathioprine, 6-mercaptopurine, and methotrexate can maintain remission. Diarrhea can also be controlled by loperamide 4 to 16 mg per day, diphenolxylate 5 to 20 mg per day, and in some cases cholestyramine 4 grams 1 to 6 times a day. The mechanism of action of cholestyramine is binding bile acids and eliminating their known cathartic action. More than 3 out of 4 patients with Crohn's disease will require surgery within the first 20 years of the onset of initial symptoms. Abscess and fissure formation is common. Abscess can be characterized as intraperitoneal, visceral, retroperitoneal, interloop, or intramesenteric. Signs and symptoms are worsening abdominal pain and tenderness, fever, and possibly a palpable mass. Retroperitoneal abscesses may cause hip or back pain and difficulty ambulating. Fistulas are the result of extension of the intestinal fissures seen in Crohn's disease into adjacent structures. The most common sites are between the ileum and the sigmoid colon, the cecum, another ileal segment, urinary bladder, vagina, or the skin. Suspect an internal fistula when there are changes in the patient's symptom complex such as bowel movement frequency, amount of pain, or weight loss. Obstruction is the result of both stricture formation due to the inflammatory process and edema of the bowel wall. The distal small bowel is the most common site of obstruction. Symptoms include crampy abdominal pain, distension, nausea, and bloating. Perianal complications include perianal or ischiorectal abscesses, fissures, fistulas, rectovaginal fistulas, and rectal prolapse. These are more commonly seen in patients with colonic involvement. Major gastrointestinal bleeding is rare. Bleeding results from erosion into a vessel in the bowel wall. Toxic megacolon is also uncommon but is associated with massive gastrointestinal bleeding in over half cases. When bowel symptoms are present, malnutrition, malabsorption, hypocalcemia, and vitamin deficiency can be severe. In addition to the complications of the disease itself, are complications associated with the treatment of the disease with mesalamine, steroids, immunosuppressive agents, and antibiotics. These include leukopenia, thrombocytopenia, fever, infection, profuse diarrhea, pancreatitis, renal insufficiency, and liver failure. The incidence of malignant neoplasm of the gastrointestinal tract is 3 times higher in patients with Crohn's disease than for the general population. Ulcerative colitis is a chronic inflammatory disease of the colon. The inflammation tends to be progressively more severe from the proximal to the distal colon. The rectum is involved nearly 100% of the time. The characteristic symptom is bloody diarrhea. The cause is unknown. It's more prevalent in the United States and Northern Europe than in other parts of the world, and peak incidence occurs in the 2nd and 3rd decades of life. It is more common in men. Ulcerative colitis involves primarily the mucosa and submucosa compared to Crohn's disease, which is a full thickness lesion. Microscopically, the disease is characterized by mucosal inflammation with the formation of crypt abscesses, epithelial necrosis, and mucosal ulceration. The submucosa, muscle layer, and serosa are usually spared. In the usual case, the disease increases in severity more distally, the rectosigmoid being involved in the vast majority of cases. In the early stages of the disease, the mucous membranes appear finely granular and friable. And in more severe cases, the mucosa appears as a red, spongy surface dotted with small ulcerations oozing blood and purulent exudate. In very advanced disease, one sees large oozing ulcerations and pseudopolyps, which are areas of hyperplastic overgrowth surrounded by inflamed mucosa. Clinical features and course of ulcerative colitis vary and depend on the anatomical distribution of the disease in the colon. Crampy abdominal pain, bloody diarrhea, and tenesmus are typical symptoms. The disease is classified as mild, moderate, or severe depending on the clinical manifestations. Patients with mild disease have fewer than 4 bowel movements per day, no systemic symptoms, and few extraintestinal manifestations. Of all patients with ulcerative colitis, 60 have mild disease, and in 80% of cases, the disease is limited to the rectum. Occasionally, constipation and rectal bleeding are the presenting complaints. Progression to pancolitis occurs in 10 to 15% of patients with mild disease. Moderate disease is seen in 25% of patients. Patients demonstrate a good response to therapy. These patients usually have colitis extending to the splenic flexure or left-sided colitis but may develop pancolitis. Patients with severe disease constitute 15%, and it is associated with frequent bowel movements, anemia, fever, weight loss, tachycardia, low serum albumin, and more frequent extraintestinal manifestations. Patients with severe disease account for 90% of the mortality from ulcerative colitis. Virtually all severely affected patients have pancolitis. Ulcerative colitis is usually characterized by intermittent attacks of acute disease with complete remission between attacks. Sometimes the first attack is followed by a prolonged period of inactivity or the disease is chronically active. The factors associated with an unfavorable prognosis and increased mortality include higher severity and extent of disease, a short interval between attacks, systemic symptoms, and onset of the disease after 60 years of age. Laboratory findings in patients with ulcerative colitis are nonspecific and may include leukocytosis, anemia, thrombocytosis, decreased serum albumin, and abnormal liver function studies. There are many biomarkers for diagnosis and prognosis, but none are available in the emergency room. Therefore, the diagnosis of ulcerative colitis rests on the following: a history of abdominal cramps and diarrhea, mucoid stools, stool examination negative for ova and parasites, stool cultures negative for enteric pathogens, and confirmation of the diagnosis by colonoscopy. Major diseases that should be considered in the differential diagnosis of ulcerative colitis include infectious colitis, Crohn's colitis, ischemic colitis, radiation colitis, toxic colitis from anti-neoplastic agents, and pseudomembranous colitis. When the disease is limited to the rectum, consider rectal syphilis, gonococcal proctitis, lymphogranuloma venereum, and inflammations caused by herpes simplex virus, Entamoeba histolytica, Shigella, and Campylobacter. Patients with severe ulcerative colitis should be treated with IV steroids, replacement of fluids, correction of electrolyte abnormalities, broad-spectrum antibiotics, mesalamine, and steroids. IV cyclosporin at 4 mg per kilogram per day or infliximab can be effective in fulminant colitis non-responsive to IV corticosteroids. When toxic megacolon is suspected, place a nasogastric tube and obtain imaging and surgical consultation. The majority of those with mild and moderate disease can be treated as outpatients. In the treatment of patients with mild active proctitis, proctosigmoiditis, and left-sided colitis, which is less than 60 centimeters of active disease, topical treatment with mesalamine suppositories or enemas is effective. Although not as effective for inducing remission as mesalamine, topical steroid preparations such as beclomethasone, hydrocortisone, tixocortol, and budesonide are successful and better tolerated. If topical therapy is unsuccessful, glucocorticoids are effective in inducing a remission in the majority of cases. Daily doses of 40 to 60 milligrams of prednisone are usually sufficient and can be adjusted depending on the severity of the disease. A combination of oral with 2.4 grams per day and topical mesalamine is used in the treatment of acute mild to moderate attacks but is inferior to steroids in more severe cases. In addition to sulfasalazine, the newer 5-aminosalicylic derivatives are quite effective in inducing remission of ulcerative colitis as well as maintaining it. The choice of agents available for the treatment of ulcerative colitis is very similar to that in Crohn's disease. Topical glucocorticoid enemas or 5-aminosalicylic enemas such as Rowasa or suppositories 500 milligrams twice a day are quite effective in distal proctosigmoiditis and have lower systemic side effect profiles. Infliximab is the only biologic indicated for ulcerative colitis. Hydrophilic bulk agents such as psyllium can be used in some patients to improve stool consistency. Antidiarrheal agents are generally ineffective and may precipitate toxic megacolon. Blood loss from sustained hemorrhage is the most common complication, but toxic megacolon must not be missed. It develops in advanced cases of colitis when the disease process extends through all layers of the colon. The result is a loss of muscular tone within the colon with dilatation and localized peritonitis. If the colon continues to dilate without treatment, signs of toxicity will develop. Plain radiography of the abdomen demonstrates a long continuous segment of air-filled colon greater than 6 centimeters in diameter. Loss of colonic haustra and thumbprinting representing bowel wall edema may be seen. The distended portion of the atonic colon can perforate, causing peritonitis and septicemia. Mortality is high. A patient with toxic megacolon appears severely ill. The abdomen is distended, tender, and tympanitic. Severe diarrhea with more than 10 bowel movements per day is often seen but may have ceased. Fever, tachycardia, and hypotension are typically part of the clinical picture. Leukocytosis, anemia, electrolyte disturbances, and hypoalbuminemia are the supporting laboratory results. Some of the more prominent features of toxic megacolon, such as leukocytosis and peritonitis, can be masked in the patient taking corticosteroids. Antidiarrheal agents, hypokalemia, narcotics, cathartics, pregnancy, enemas, and recent colonoscopy have been implicated as precipitating factors in toxic megacolon. Medical therapy with nasogastric suction, IV prednisolone 60 mg per day or hydrocortisone 300 mg per day, parenteral broad-spectrum antibiotics active against coliforms and anaerobes, and IV fluid should be attempted as initial therapy along with early surgical consultation. Perirectal fistulas and abscesses may occur in up to 20% of patients with ulcerative colitis. Massive gastrointestinal hemorrhage, obstruction secondary to stricture formation, and acute perforation are other complications of the disease. There is a 10 to 30-fold increase in the development of carcinoma of the colon in patients with ulcerative colitis. The major risk factors for the development of carcinoma of the colon are extensive involvement and prolonged duration of the disease. The cumulative risk of cancer after 20 and 30 years is 5 to 10% and 12 to 20% respectively. Additional factors that constitute increased risk of cancer in patients with ulcerative colitis include early onset of the disease and family history of colon cancer. Our source is Tintinalli's Emergency Medicine. Thank you.